Hello, everyone. Welcome to the Global Brain Health Clinical Exchange. Good morning, good afternoon, good evening, wherever you're joining us from around the world. We've got a really exciting session today. This is Data Saves Lives, partnering with industry and shaping AI to improve global brain health. It would be great to hear where you're joining us from, so please do send us a message in the chat. Tell us which country you're joining from or what your role is. So today we'll have our chair, Professor Iain Buchan, and he will introduce our speakers. We've got a really exciting couple talks today. And just a bit of housekeeping, the webinar is being recorded. If you want subtitles, you can change the language if you navigate to the closed captions function. Your camera and microphone are disabled, but please send us messages in the chat, ask questions, and we'll have a long, good interactive panel towards the end, so there'll be plenty of opportunity to hear the speakers respond to your questions. So this is a map of where everyone's joining from. It's really exciting to see 78 different countries are represented. And finally, you can get a certificate for joining the session. We'll share the QR code at the end. We just ask that you fill in a feedback survey. It's super helpful for us. And so without further ado, I will hand over to our chair today. It's Professor Iain Buchan. He's Director of the Civic Health Innovation Labs in Liverpool. He's a public health physician and a data scientist and has been developing digital interventions for health systems since the 1990s. So over to you, Professor Buchan.
Thank you, Greta. And it's wonderful to be here today. I have the pleasure of introducing Dan, Gary, and Nadia. We work together in the UK's mental health mission in a data science and engineering innovation called the Mental Health Research for Innovation Centre. And they will speak to you about this work, and feel free to ask us questions in any direction. Dan, Professor Dan Joyce, is Professor of Connected Mental Health at the University of Liverpool and a consultant psychiatrist at Merseycare NHS Foundation Trust here in the UK. His first training is in computer science and then medicine and psychiatry. He's interested in statistical and machine learning to deliver actionable insights for service users, patients, and clinicians for better mental health. He's focused on defining transdiagnostic phenotypes and developing unobtrusive, low-burden ways of measuring and tracking clinical and health states using technology, and aligning that work with AIs that can work for patients and clinicians in practice. Gary Leeming is Director of Liverpool City Region Civic Data Cooperative, which is the first of its kind, a civic data cooperative. He's Chief Technology Officer here at the Civic Health Innovation Centre at the University of Liverpool. Gary's a software engineer by background and has worked for over 15 years on progressive uses of health data for research embedded in real-world health and wider social and civic systems. Gary has engineered impactful, large-scale data uses for clinical trials, such as the Salford Lung Study by GSK, population health initiatives, such as the Connected Health Cities programme in the north of England, and most recently, some of the data responses of the COVID-19 pandemic in the UK. Nadia Lipunova is Vice President of Real-World Evidence at Holmusk. Nadia is a genetic epidemiologist by background, and she has over 10 years' experience in real-world data and their uses in international health policy development, academic research, and commercial project delivery. So it's my great pleasure now to hand over for the initial presentation to Dan.
Thank you, Iain, for the introduction, and thank you all for having us here to speak with you today. So to kick things off, what I'd like to do is focus on if we imagine a fictional patient presenting to a healthcare professional at 3 o'clock in the morning in an acutely distressed, upset, tearful, anxious, frustrated way, the questions that we have to ask for that patient are, what's going on, why is it happening, and what can we do within the network of health services we have available to help them. So on this slide, if you look to the far left, you have what we might call the traditional kind of biomedical model. It assumes that depression and anxiety, for example, are two discrete diagnoses that have clear boundaries. There's some amount of overlap that we allow, and we call that overlap comorbidity. But generally speaking, there are sharp boundaries between different conditions. There are sharp boundaries between mental illness and an absence of mental illness. They are represented, if we think of this as a diagnostic testing scenario, there are a finite and small number of signs and symptoms that define depression, and similarly for anxiety. And finally, we assume that the measurement of those signs and symptoms is reliable. It can be measured with the person or on the person. This is what psychiatrists would love the world to be like. In an ideal world, this would make our lives substantially easier, but the reality is very different. So if we zoom out a little to the biopsychosocial model, so Engels' 1977 lauded model of how medicines should approach the problem of diagnostics and healthcare and treatment, we have to acknowledge that a person doesn't live in a vacuum, that problems don't live in the patient. The problems are often relational and relate to the people and places around them. So in a biopsychosocial model, we're prepared to concede that the definite boundaries between different diagnoses are actually quite blurry. We acknowledge that there are, or we at least define operationally, a set of measurable or indirectly measurable and a finite but quite large set of signs and symptoms that we think point us toward or away from a diagnosis. So rather than saying we are definitively sure this person has a depressive disorder, we actually say there's a sort of probability that this is depression, but there's also a probability that this might represent an anxiety disorder, post-traumatic stress disorder, and so on. So we think in a much more probabilistic, or not completely certain way. The consequences of the biopsychosocial model are that you actually have to look wider than the relational network of the people that you see as the index patient. If we take a population health lens, those boundaries become open and porous and even more blurred. What I mean by that is a person and their network of people don't live in isolation. They're surrounded by a superstructure, which includes the social and economic environment that they live and dwell in. So in a population health lens, the problem becomes much bigger, much blurrier, and the boundaries of different diagnoses become open because you can't be certain that you're dealing with a disorder. You might be dealing with someone's entirely explicable reaction to difficult or perverse circumstances. It's not entirely clear that the causes of someone living in a social and economic network are actually finite or that they can be measured. And we certainly don't know, we don't really have a handle on the size. And what the population health lens on mental illness tells us clearly is we can't rely on data that describes patients at just the individual level. So on the left of my diagram here, the biomedical approach, we know that we need more time and space about the patient. We need measurements that are frequent and detailed about the patient. In the middle, back to the biopsychosocial model, we need data that surrounds the patient at different spatial scales. And that's to say, what is the network around the person? And then finally, at the population level, you have health and determinants of health that are social, political, and economic. And that requires data that tells us about different time scales both for the patient and the things around them, but also different spatial scales. So not just locating the problem with the patient, but looking at other spatial extents, or the diameter of influence that of factors that impact on how a patient presents when we see them. So here's where we are at the moment. If we adopt a biomedical model, I explained that we assume that these boundaries between diagnoses are discrete and easy to demarcate. But if we look at evidence on comorbid patterns, and the diagram here is from Quanatel's paper, if you pick depression as the diagnosis, and then you say, in UK, this data is entirely UK centric, but it explains the point rather well. If you ask, what disorders do people commonly have if they have depression? So conditioned on having depression, what other disorders do we find leap out of population level data? Population in the sense of epidemiology, we find that anxiety, pain, allergies, cardiovascular disease, and metabolic syndromes all jump out. So patients with depression frequently have these comorbid patterns. So the question is, we need to use data that gives us signals about why these different disorders might be comorbid. And we have to acknowledge, and we have to be open, that we know that those signals will be sensitive to properties of a disorder, but they certainly won't be specific. And that's what we learned as we went from the left to the right of that first slide. So to put that just into a final piece of context, if you back to our fictional patient that we meet at 3 a.m. in a state of heightened distress, presenting tearful, apparently low in mood, but very anxious, very agitated, what we would do if we adopted the biomedical model in its entirety, so this is what psychiatrists would ideally like the world to look like, we would find that using the ICD-10 criteria, we would find that you would try and allocate depression as being the cause of the anxiety that you're seeing. And that's made concrete in the actual diagnostic coding for ICD-10. So it says if your symptoms could be better explained by an underlying depressive disorder, well, then diagnose depression, not an anxiety disorder. So that simple causal pathway, looking just at the patient, is, well, they have depression and that's why they're anxious. If we broaden it out to the biopsychosocial pathway, we might say, well, I recognize that this patient has been living for years with a pain syndrome. That may well give us some description about how and when they became depressed. And that might then in itself explain why they are presenting today in crisis, in a very anxious state. But the point here is trying to establish that causal pathway from when the person first developed a pain syndrome, when there was an emergence of the constellation of signs and symptoms of depression, and how they then go on, or they transform or move around to look more like anxiety. That causal pathway can be explicated, but you need more granular, time-based data about the patient and their surroundings. And finally, at the bottom here, the population health model would ask two separate questions. The first one is, what are the superstructural issues that surround this patient? So to give you an example, if the economy tanks, so people living in a region are subjected to adverse financial pressures because their economy isn't doing well, this might impact on their working life and their occupation. So they may lose their job or have to take work in a different occupation. This might impact their personal finances, so they then end up moving to cheaper, less suitable accommodation. In that accommodation, they're exposed to new substances and pathogens. They develop an allergy to those particular sets of environmental substances and pathogens. Because they now have a combination of ill health and inability to fund their lifestyle, there's an impact on their lifestyle, which means, for example, they may not be able to exercise or take care of themselves in terms of nutrition quite so well. So if I can understand that superstructural network, I need data that spans a number of different spatial diameters factors. It can't just be data on the patient. It has to be data that tells us about the patient. Data from their healthcare records is one thing, but data from their other, for example, public sector organizations that might be assisting them, so social care, the housing system, access to welfare and benefits, all of that information exists way outside the patient, but clearly is on the causal pathway to explaining why our patient has ended up in crisis at 3 a.m. in the morning. With that superstructural information at a large scale, and probably at quite a slow time scale because those factors don't shift very quickly, I can then use that superstructure to start to explain the comorbid pattern that we've brought over from the second slide that I showed you. So if I know that a person has developed pain because they had an accident at work and then they have been financially impacted and then they've had to move to inappropriate accommodation, I can piece together the time course of how these different comorbid diagnoses have come together. So I might find that the pain, depression, and anxiety cluster of diagnoses sits alongside or interacts with the superstructural socio and economic factors that lead to a degradation of that person's lifestyle, which means they stop looking after themselves. They make poor or maladaptive choices about their lifestyle. They develop cardiovascular disease. They start to develop a metabolic syndrome, and they're exposed to pathogens in their environment that give them an allergy. So the demand that mental illness places on us as data scientists and healthcare providers is looking through that population health lens. I require access to data that has different timescales and different spatial scales and crosses the boundaries of healthcare, social care, education, and so on. At that point, I'm going to hand over to my colleague, Gary, who will now explain to you how technology can be used or leveraged on this problem. So Gary, over to you.
Thanks, Dan. So within the Mental Health Research for Innovation Centre, we have been spent some time basically building on what has been a number of years worth of work thinking about the patterns of what a trusted research environment would look like. How do we assemble data for researchers to use that is considered quite sensitive and can be shared with researchers in a way that our patients and our publics can trust? And we've engineered this solution with colleagues from Microsoft in particular to look at how we can also solve some of the challenges that Dan's been talking about around the different types of data that we would receive and what we need to do in order to link it. So at the moment, what we have is a data pipeline that allows us to process this data through different states in order to be able to use it for research. So at the moment, we are receiving information from the electronic health record system that the Mental Health Trust, the Mental Health Hospital uses. That also includes, is extended with extra data such as medications. And we're in the process of increasing that data size to include other types of data sources, such as education and community services data. When that data arrives, it's almost like a kind of Tower of Babel. There's lots and lots of different types of data, even from within the single data source within Rio. And that covers around about 1 million people, but is many, many gigabytes, even, starting to edge towards over a terabyte of data in terms of the different types of information that we have there. Some of it is structured, so it's relatively easy for us to process, but much of it, especially the bits that are the most useful for Dan's work, are unstructured. They're clinical notes. They're the notes that the doctors, the nurses, and people are writing for themselves in the clinic. So once we've started to check the data quality and the linkage of the data, we move that from what we call a bronze layer to our silver layer, where we can start to look at what additional processing can we do? And that might be interaction with services such as that provided by Holmusk, but also we're doing a lot of natural language processing, which is bespoke, we think, to mental health, where there can be a lot of terms that have medical definitions, but aren't necessarily so used in that way in the record. So a person or a patient might present and say, I'm feeling depressed, and that might be recorded as the person is depressed in their record, but it doesn't mean that they have depression that day. But it might do, you know, there might be that. So in terms of how we teach computers to understand what the difference is something that we're focusing on at the moment in terms of how we understand both those specific interpretations of the terms that are used in the record, but also how do we then sort of stretch and link that out to those other data sources, such as actigraph information that captures how mobile a person is, how much do they move around. That's captured as sort of time series sort of points of movement data that could also be linked to this information. Often also, as Dan says, given at a completely different scale or pace in terms of how those data are recorded. Those data may be available on a daily basis or even an hourly basis, while the clinical notes may only be available on a sort of monthly or 6-monthly basis, depending on the visits. Once we've assembled that data, we then anonymize it, so we remove all of the identifiers from the data. We've also mapped it to OMOP at that point. So OMOP is a common data standard, and the reason for using OMOP is that that's something that we're using across the UK at the moment, increasingly to help us to link and create queries that can be shared across different services. So it would allow us potentially to link to other NHS data sets with a single query to find common attributes across the data. We also provide a data catalog, so make it easier for the researchers to find and identify the data that they want to use, and they can work to apply to our data asset and access group, apply for the access to the data, and then that data can be provisioned in their trusted research environment, which will be a specialized virtual machine with just their project data available to them. So we're preserving privacy for the patients while also providing any tools that the researcher needs, which could be anything from R up to sort of more modern sort of machine learning type tools that may be provided within the cloud. Next slide, please, Tom. And now that we've kind of done that, we're starting to move on to this next stage of how do we really start to answer the types of questions that Dan's raised, and what does that sort of look like? And so we're seeing the data coming in from the bottom left-hand side of this slide in those different forms of information into what we're calling an avatar model. So an avatar model is almost like a digital twin, which allows us to assemble those different types of data in a way that we're hoping will be understandable or interpretable by the algorithms that are developed. And in that then becomes almost like a graph structure of the data, as described in the sort of middle right of the thing, that allows us to say these are the different pieces of information that we know about this person that are appropriate for this algorithm, that we can then use to sort of query and return a result back. And to do this, then that means ideally that we'll also be able to work more closely with the data sets themselves to overcome the challenges of the data being stale or out of date in terms of how it refers to that individual patient. So part of what we're hoping to do as part of the next stage is to make sure that that data pipeline happens in a very rapid way, so that the data are usable by clinicians at the point of care. So let's peek into the future there, and I think I'll hand over to Nadia now. So thank you very much.
Thank you very much. So I will shift the gear a little bit and present a perspective of the industry now, or industry-related perspective. Now, I work for Holmusk that can be briefly summarized as a company working on real-world data in psychiatry. And by what I mean saying real-world data is all data that is collected outside of clinical trials and represents routine healthcare. So it's really aiming to describe experiences of patients who just operate in their daily life. Now, at Holmusk, we see mental health being the global challenge of our lifetime. That is partially driven by the rising impact with prevalence rates and burden of the diseases across all psychiatric conditions still increasing since early 1990s. Now, that is multiple decades of psychiatric conditions not only retaining their importance, but increasing the burden. Unfortunately, the outcomes for these patients are also worse and are the second leading cause of years' lives lost due to disability. You will very frequently see mortality figures being reported as the main estimate of burden, and that is not entirely reflective of the burden that psychiatric illnesses present, but they are just as important, as patients are very constantly presenting with chronic conditions and they experience the burden in their daily lives that may continue throughout their lifetime. Now, there are many reasons why the prevalence and the prevalence increases and the outcomes are still poor for those patients. Now, one of those reasons is what is known as efficacy effectiveness gap. And what efficacy effectiveness gap is, in simple terms, is the difference between the performance of an intervention, let's say a medication, in a clinical trial, and the performance of the same intervention in routine practice. Clinical trials are highly rigid and designed to be such to essentially ask the question or answer the question, can an intervention or can a medication work in principle? But what routine practice is primarily interested is answering the question of whether or will the intervention work. So they are related, but they are slightly different questions. And the reality is such that clinical trials represent a small fraction of all patients living with a particular condition. And sometimes it's very difficult to grasp just exactly how big the gap is. So at this point, I would like the audience to take a wild guess and zoom in on topic of schizophrenia, which is very important in the context of mental illness. And just take a wild guess on what is the proportion of patients with schizophrenia who would not be eligible for clinical trials. So who are not represented in the data that we most frequently consider as saying, yes, this approach works or this approach doesn't. Now we'll give a few seconds to submit some of the responses. Hope to see some answers in the chat. And we can see that majority of, thank you for audience's answers. Majority of us think that 60% are not represented, followed by 80% of patients not represented, and subsequently 40 and 20. Well, very close. It is, in fact, 80%. So clinical trials show that only 20% of real world individuals with schizophrenia spectrum disorders fall into clinical trials. Now, 80% is a figure worth stopping for because it is staggering. It means that majority of patients to whom these medications interventions are provided to never have a chance to be actually represented. And that may be okay, but the reality is that those patients are different from patients in clinical trials. They are heterogeneous. And most importantly, research shows that underrepresented populations or patients do have worse outcomes. So you can argue that those patients actually are in a need or in a higher need or more significant need of an intervention. So that gap is significant and it's present in psychiatry, but it's present across all therapeutic areas. Now, this is where we can consider what can real-world data and evidence and AI do in psychiatry. And the reality is there are multiple points of impact, with always considering two key pillars: routine practice and clinical research or development. Now, first of all, we, especially at Holmusk, we suggest to start with routine practice because we want to understand what the patients look like and how do they come in, as something that Dan and Gary have described. And what don't we want to look at what the patients are actually experiencing before we go into the clinical development route? And today, AI and data can be easily is a strong word, but at least more efficiently deployed to data curation enrichment. And that addresses a very significant gap. So something that Gary has touched upon. All of that work is incredibly laborious, long-lasting, and very frequently is not performed in any hospitals or healthcare providers. But with data engineering tools and AI, those data can actually be accessible for researchers and also clinicians or healthcare staff to ask and answer questions about their patients. Now, very importantly for myself, being an epidemiologist, I really want to send patient population and their needs. And with that, having those answers to inform clinical development pipelines to make sure that the most important needs and populations, diverse populations, are actually represented in the programs. Now, following that, we can continue the cycle with actually assessing the impact in routine setting, because in reality, this is what we want to see moving. We want routine setting to adopt certain interventions that are effective and that are cost-effective, and those to be implemented for patients. We can also assess long-term outcomes, and I mentioned cost-effectiveness, which is very important for whole of healthcare system to adopt and interventions. And the cycle continues essentially indefinitely, but it has to be informed by data with clinical oversight. Now, what we do at Holmusk is we address the data gap, because very frequently we know that there is no data, and very frequently in psychiatry specifically, the data are missing at higher rates. So what we have today and what we work for quite a few years on is to have a data set that is able to address certain questions about patients and their needs. So we currently have 30 million patients, or over 30 million patients, that are representing over 1 million treatment centers in the United States. And the treatment centers vary from primary to secondary to tertiary specialized centers to also capture a variety of conditions and different levels of severity, different socioeconomic groups, and all of those are included. And on top of that, we want to consider a multidimensional approach. So not isolate or extract only certain items of data that we think might be important, but to take sometimes a data-driven approach where both structured and unstructured data are describing patients together and giving us some clues about what kind of populations do better, worse, or might benefit from a particular intervention. Now, an example of that is something that we have presented recently on cognitive impairment and negative symptoms in schizophrenia. Now, for those of you not familiar with schizophrenia, these two symptoms domains are incredibly important in patient daily functioning. And if you ask any psychiatrist, they know these very well. However, up until very recently, literally this year, there were no treatment options for these symptoms. So patients were always worse. And it was also on top of it, not know what exactly is the percentage of patients who suffer from these symptomatologies on a large scale description. We got this information from clinical trials and some small scale descriptive studies, but we didn't know whether that actually describes the whole population. So first of all, what we were able to do is we could identify clinical features of both cognitive impairment and negative symptoms, which often was seen as not possible because they would be underrecorded. And most importantly, we were able to provide evidence that both of these symptom domains do contribute to worse outcomes. And this is where we also outlined to pharmaceutical industry an option, an opportunity to address the market, address patient populations that are in the significant need of their symptom management. Now, I will very quickly close with what we think is the future of real data, specifically from the industry perspective. And I'm sure everyone in the room will know about large language models and AI that is currently accessible to almost every one of us. Whoever who has their screen on can actually interact with an AI. And I think although they carry a lot of skepticism, as LLMs very frequently hallucinate, they are not necessarily precise or not frequently precise. And there are so many predictive models or so many models that seem to be useful, but they are just not adopted in routine healthcare because they're not always as precise as we would like them to be. But I would also like to emphasize that these new approaches of data and their analysis have to be incorporated in the new age understanding of psychiatry. And it's very frequently what we can judge from the past that financial and tech backgrounds really quickly adopt new and disruptive technologies, with healthcare always slightly lagging. And I think this today, in day and age, we are shifting a paradigm where we want to invite data-driven approaches, always carrying clinical oversight, because data can help and they certainly should. With that, thank you very much, and I'll pass over to Iain.
Thank you, Nadia. I'd like to invite all of the speakers to join me on this virtual panel. That's great. So there's a really interesting set of presentations, and we've had some questions come in already. Let me start with some of the cultural context. Dr. Ennis asks, how do cultural and societal perspectives influence the way mental illness is perceived and addressed? Dan, perhaps you could pick that one up.
Thank you, Iain. Excuse me. Thank you, Iain, and thanks, Dr. Ennis, for your question. So, at least in the way psychiatry is delivered and people are trained in psychiatry in the West, we have our diagnostic codes, our operational definitions of disorders, so ICD, DSM, and within those frameworks, so DSM and ICD, there are descriptions of so-called culture-bound syndromes, which is to say there are certain disorders that appear to be entirely encapsulated within a certain cultural context. To give you an example, in Asian cultures, I understand there's a syndrome described as M-RIC, which is an apparent complete lack of control or disinhibition that leads to people to behave in much the example that I gave you in my presentation, this kind of nebulous, non-specific, but clearly very disorganized and very chaotic way. So in the West, our model for this is to say we've got these discrete different diagnoses and disorders, and then we put a postscript on that. So we have like a little footnote which says, oh, by the way, there are other syndromes that are almost apparently bound to a particular cultural context. There's no need to have that footnote, that postscript, if you adopt the approach that Nadia and Gary were articulating, which is you view the problem as being trans-diagnostic. So you look for patterns of commonly occurring signs and symptoms in data that is collected in real-world clinical practice. So when I look at data from the UK, I will find clusters and constellations of signs and symptoms that represent the expression of depression in a, for example, predominantly white British populace. If I was to repeat the same analysis in a database residing in one of the African countries or in China or in Korea, I would get a different sets of constellations and clusters of signs and symptoms. So if you're prepared to step back from the rigid boundaries of DSM and ICD, adopt a trans-diagnostic approach, what you find is there will be commonalities between those constellations or clusters, but you'll also find that the local or the regional cultural expression of what we think depression, schizophrenia, and anxiety, PTSD are, they will emerge for themselves from the data, because the clinicians and the patients that are generating that data will be generating a culturally defined version of that. It will require that if we use, for example, technologies like large language models, it requires teaching those models how to use natural language expressions of disorders, syndromes, and it requires that they are trained specifically and very locally in the population that you intend to use them in. So I've sort of gotten around the question, Dr. Ennis, by saying, if we stop worrying about rigid diagnostic categories and we flip the problem on its head and we generate new categories, those soft fuzzy boundaries that I was showing you, if we do that for free, we capture culture, what we currently call culture-bound syndromes. So we get round that Western-centric model by actually capturing the data from the people, from the clinicians, and build new diagnostic structures on top of that. I hope that answers your question.
Thanks, Dan. We've just had an interesting question from Dr. Kierla that says burnout is rampant in just about every industry, and how might AI reduce workplace stress and improve mental health in the workforce? It requires the kind of linked data and maybe frameworks that you were talking about, Gary. Do you want to pick that one up?
Yeah, I mean, there's probably, I guess, two ways that you can look at this. One of which is the sort of pessimistic one, which is that AIs are going to take over all our jobs, and we're all going to be getting depressed, and the AIs are not going to help. But I think that there is a more optimistic version of that as well. And I think when you look at the automation across human history, you do see that, yes, while there can be initial disruption, it does free up people to become more specialized, more skilled, more capable in the roles, and take on more for themselves. So if you look at the banking sector, for example, in the UK, where you don't have so many actual branches open, so we're not employing as many people to sit behind a desk, just kind of handing money over. That seems on the face of it quite bad, but the reality is that the banking sector is now hiring more people than ever, but they're now more highly paid and more highly skilled. And we'll see that across, I think, within mental health as well. The opportunity that it will offer us as individuals to support us in terms of understanding where we are in our own sort of situation, to provide some sort of, not necessarily, I wouldn't go as far as saying therapy, but certainly a notification that maybe it is time to seek help, can also be quite helpful. It can be helpful to help us to manage what we are looking to do with our own lives in that way. And I think that's really where this idea of the avatar that sort of Dan and yourself, Iain, have been sort of working on, is where we start to look at how do we collect all of this information together across all of those different sort of spectrum of sources, and then apply it in a way that can be hyper-personalized to you and to your needs, is a real opportunity for helping us to recognize that, when we do need to just take a step back, and so we don't burn out, or when we do need to sort of bring on some of those other sort of opportunities, or even to sort of see when actually we're doing okay, that actually there's really nothing to worry about. But we do have a long way, I think, to go before those types of things can be properly validated and demonstrated to be safe and usable. And I think that's part of the challenge of where we are at the moment. And again, just swing it back to some of the risks. When you see the proliferation of mental health applications online that are not validated, that you don't know what their source of information is. You don't even know really how sticky they are. Are they still being used even after 3 months? Those types of challenge, things that are happening right now, sort of, I think that's where we need to sort of put a little bit more focus in.
Thanks, Gary. Points well made. For the next couple of questions, I'd like to turn to Nadia now, and maybe Gary afterwards would like to chip in. There's a couple of related points here. Dr. Dorkey says AIs can really support decision making, but at the same time, we need to consider real life solutions, prescriptions, costs of treatments, all of the context in which a decision's being made. And Dr. Dr. Lekama says that considering the diverse tools that are available, for example, for NLP in healthcare generally, what are we doing to make this more mental health specific? What steps have been taken to ensure that more structured data are being collected in the ongoing work, alongside tackling the Byzantium of unstructured data? Over to you, Nadia.
Thank you. That was such a perfect description. Byzantium of structured data is exactly what we see in day to day. To focus on the first question on contextual importance, I think that's a fantastic question, and something that is exactly to be addressed by real-world data, or at least providing evidence in addition to all that we know already. There are evidence or instances where, let's say, an intervention might be very effective, but it's not feasible to implement in routine practice. A different example from psychiatry, but there was a case where one intervention medication was incredibly effective for spinal muscular atrophy and was essentially open to market in a couple of countries and was welcomed with very low adoption, even though it's highly effective, which made people scratch their heads about why on earth it's not working. And it was found out that it was only provided in a few centers and patients are physically unable to travel to receive the medication. So this is where the gap in terms of medication access, how do patients interact with healthcare system, was just an oversight, an unintentional one, but it has to be brought into the clinical development. So to the question, yes, context is always important, and analyzing of patients' interactions with healthcare system, both on just utilization domain and also in terms of their disease and condition and what implications that particular condition may have, are key to bring back into clinical development for medication adherence, for feasibility, and for estimated burden. Now, to move on to the second question in terms of how many tools or what tools are available for mental health specific NLP curation, the reality is there are some, but they're inconsistent, I would say. The very good news is that in today's world, NLP or the baseline models are accessed easily, and that's massive benefit, where we have essentially the baseline that is most work and that is the most difficult part, and they are available, they're open source, they're freely available, and essentially anyone can use them. On top of that, those models specific to mental health can be further developed, and that's a little bit more work. There are a few occasions where they have been developed but aren't used globally, but it's something to consider. So the baseline is something that is freely available, such as Hugging Face, if anyone is into NLP development. And based on those, the work specifying cases is much more simple, which hasn't been the case 10 or 15 years ago. And final point in terms of how to bring structured data recording, this is what we live and breathe. And I am by no means a clinician, but one thing that I consider, or we consider when thinking about how to increase coverage of structured data, is to also make it simple. You will very frequently hear researchers, also myself, say, well, we need all the data. We need everything that you can get us. But that's not feasible. We have to consider day-to-day clinical practice where data recording on its own is really not the direction that people would like to go, nor is there time to do this. So by understanding what really matters to measure or what to record, we want to really synthesize those few items that are meaningful and then focus on those that matter. So how to increase the coverage, to really understand what matters and to focus on those rather than just ask for recording of everything.
Thanks very much, Nadia. Time's running a wee bit short, so I'm just going to take one more question now, which is a really important point that Dr. Candle has raised, that our training data, in a world of more big data uses and AIs, the training data are much denser in higher income countries, but some of the greatest mental health needs in society around the world are in the low to middle income countries. Is that something that you'd like to comment on, Gary?
Yeah, sure. And if Dan or Nadia want to jump in, then please do, because I think it is a really critical question. And part of the answer actually is building on what Nadia was just saying there about, the need to, recognize generally that, we will say that we need all of this data, but possibly we don't. Possibly we only actually need 3 or 4 sort of key pieces of information that can help us to do with these things. So something as simple as looking for step changes in somebody's movement patterns, which could be derived from different relatively cheaply acquired sources, could be a tool that we could sort of potentially use. So it's understanding how we sort of can redeploy some of those algorithms in that way. The second part to that is as well, though, is that in lower middle income countries, although there is paucity of data of some types in terms of some of the clinical records, there are many programs that are starting up, especially in the open source movement, that can help us to sort of deploy technologies that can sort of help to collect things. There are sort of cheaper devices, and I think we can put some support I think out there to help with people being able to sort of take greater ownership of their own care in areas where they can't access those services anyway. And we need to sort of think about those things. And again, I think that's something that Nadia definitely was touching on as well. So, I think there are also obviously potentially risks, moving things into different environments, different languages, different challenges, especially when we're using some of these large language model type approaches, does introduce risk, in different cultural circumstances. But there might also be other opportunities in, sort of overcoming some of those barriers that people have in terms of sort of recognizing mental health as something that should be sort of managed and supported as well. I don't know if either Dan or Nadia has anything you want to just add to that.
I was scrolling through the questions and comments in the chat. And I think, forgive me if I mispronounce your name, but Amit Kandel made the point about how would this ever apply to countries where we don't even have simple electronic health records. So Amit, I don't mean to in any way devalue the point that you've made, and I hope this doesn't appear to be frivolous, but I think the point is, even in environments where we have electronic health records, we are beginning to learn that what is in them actually doesn't have a great deal of clinical value. So being someone who spends a lot of their days in front of electronic health records, about 80% of the free text data has no value to me as a clinician. It's either medico-legal or administrative or insurance related. So here's a slightly positive reframing of your question that I hope doesn't get interpreted as frivolous, but there's an opportunity to do this better the first time round. So rather than import the 30 odd years of EHR history that we have over here in high income countries, we have the opportunity to do what Nadia was suggesting, which is what is the actual data that we need to collect and how can we do it? And I think there are two approaches. One is to look at translating low-cost, repurposed technology to help collect that data, to focus it in on the things that people care about and that matter to them. I'll pick up Gary's point from the avatar slide. If it turns out all I really need to know is roughly how active you are and whether or not your circadian cycle is in sync with the sun and the moon, I can give you a cheap piece of technology that will help collect that data, that is not burdensome to you, the patient, and tells me way more than I would ever get from sitting down and in the style of a clinical trial, asking you to complete 5 or 6 patient-reported outcome measures, and as a clinician, completing 5 or 6 structured interviews and then codifying all that data on an EHR. So I think there are opportunities to innovate by repurposing relatively cheap off-the-shelf technology to collect the useful data for the clinical context in which it will be actioned. So back to my example, if we gave you a cheap actigraph, it may be that data is much more useful for trying to intervene on a patient's depressive disorder or even a psychotic spectrum disorder than rolling out 30 measurements using the PAN scale for psychotic symptoms in schizophrenia. I hope that doesn't come across as frivolous, Amit. It wasn't intended that way, but there is an opportunity to do something novel from the ground up in countries that don't have the luxury of an EHR system, but are also not burdened by the consequences of that EHR system and the way we have perhaps too much organized our healthcare provision around it.
Thanks, Dan. Well put. So it just remains for me to sum up this discussion of a vast space. Many of you study brain health in quite molecular and clinical ways. We've had a wide-ranging discussion about the social and environmental context. We're looking at a remarkable interaction of biology, behavior, and environment in most of mental health, with huge variation around the world. Where our social, built, work, diet, alcohol, physical activity environments create enormous differences in how a treatment might work, in how the rhythms of daily life manifest in increasingly cheap and commonplace technologies of providing data that we barely understand Yet Nadia's shown us that 80% of our conventional clinical trials from conventional EAHR data that Dan and Gary have shown do not contain all that we need. That pit stop view doesn't give you the rhythms of life that are extremely interwoven with brain health. So how do we use those data? Well, first, we need to start by taking the global view of this vast variation of treatment outcomes by the contexts in which people live and experience mental health. That needs us to have a big picture of research, the flowing of data, and the social conversation about what we do when the models say this doesn't quite translate from this population to another population. How do we pull in more data and people like you to think together in abstract around the data, craft better models, better therapies, drug and digital therapies for mental health? So thank you for listening. And back to you, Greta.
Thank you. I think that's a really exciting and positive way to bring this together. So we'll just finally advertise some or share some opportunities to be involved in global brain health. So firstly, we actually previously had a joint session with the Global Brain Health Institute, and they have the Atlantic Fellows Programme. And they recruit fellows internationally from all over the world, completely intersectoral. This isn't just medics. They might have musicians or town planners looking at how you can improve brain health, particularly dementia, but also more broadly. And there's a QR code there. They're having a session on Monday to try to introduce the programme and give you a chance to ask questions about it. Secondly, this is something I've come across recently. It's a social enterprise actually founded in Nigeria called Aureus Medical. They offer therapy, but they also have training in mental health and really about being a mental health first aider. It's 4 weeks, I believe, and it's virtual, and it only costs $15. And there's been some quite positive feedback. So have a look there and see whether that's something that you might be interested in. If you would like a certificate for the event, it's possible to do that if you follow this QR code and give us some feedback. Or even if you're not interested in the certificate, it is hugely helpful to keep this programme going, to have that feedback and to learn kind of how you're translating what you learned today to change in your setting. We do just have a couple polls, so I'll ask these to be launched now. And this is to help us understand whether or not what you're learning today will change something that you do in your setting. So if you could please click, this first one is just, there's at least one thing that I will do differently or act on as a result of attending this workshop. I really hope we get some yeses there. I think we got some really positive comments about practical things that people can do in their setting. Okay, so we've got about a third of responses there. I'll just wait another couple seconds. There we go. Fine, so that's really positive. Thank you very much. That's helpful for us. And then just finally, we'll go on to our next session. So this is actually, it's going to be our final session. So this is looking at the UK national guidelines on the management of encephalitis in adults and children. What have we learned over the last decade? So there's been enormous change in encephalitis over the last decade, particularly about autoimmune and immune mediated causes. And even though the UK guidelines, I think there's lots of relevant points everywhere. So if you could join us next month, that would be fantastic. So thank you very much for joining. Thank you very much for our chair and our fantastic speakers, and hopefully see you next month. Goodbye.